Alrighty, it's 12 o'clock, so we will go ahead and get started. Welcome to COVID tips. And we want to wish everyone a happy Nurses Week. Today is actually International Nurses Day. We know nurses are an incredibly important part of our care teams and to our immunization system. We rely on nurses a lot to educate patients, administer vaccines, but also to help lead those clinical teams and work with your medical assistants who do a whole lot of the distribution and the back end accounting and things like that. So thanks to all our nurses, and hope that you all get to celebrate all that you do a little bit today. Our case counts continue to slightly increase. We are at about 866,000 COVID cases. Our COVID vaccine rates also continue to climb. We have passed the 5 million vaccine mark in Arizona. Almost 5.2 million vaccines have been administered in Arizona. And sadly, 17,367 individuals have died of COVID-19 since the beginning of the pandemic in Arizona. A couple of things that are new this week. So Moderna storage and handling change. You can now, it used to say room temperature for punctured vials. Room temperature means something different here in Phoenix than it does in Flagstaff, especially this time of year. There is a typo on this from CDC, which we've let them know, but punctured vials should now be stored between 2 degrees Celsius and 25 degrees Celsius, or 36 degrees Fahrenheit, 77 degrees Fahrenheit for up to 12 hours. So that's new. Also new this week, you all started ordering your Moderna doses via ASIIS. Remember, you can order 200 doses every 2 weeks. If you're doing a mass event and you need more than 200 doses, just put that in the notes section. For ADHS, we know a lot of you are still doing pods with more than 200 people. No changes were made to Johnson & Johnson. That is still ordered through your county. And we are all getting lots of questions. We expect that Pfizer, the EUA, will be updated in the next few days, hopefully, to go down to age 12. So, and remember, this is only for Pfizer. It's not for Moderna. So only we expect Pfizer will go down to age 12. If you are you're going to be requesting Pfizer through your counties still. If you're in Maricopa County, you should have gotten an email yesterday from the allocations team. They are asking you to make those Pfizer requests now. For your pediatric patients, so that they have an idea of, and then you'll be able to hold on to it until that, so that you're ready when the EUA goes down. So check your inbox for an email if you're in Maricopa County about Pfizer ordering, and those emails are sent to the primary ASIIS contact. Another new change, there's a couple changes this week. So VFC and COVID order approvals, you will no longer be getting those courtesy emails saying your order is approved when it gets approved in ASIIS. Instead, you need to log into ASIIS to check the status of your order. So you got an email about this, I think this morning. And you'll have these slides. You can look through how to check your orders. So we'll just make sure that we send these out to you after the session. Okay, so last week there were questions about wastage that were popping up in our chat box. So we did ask DHS to clarify with CDC if there were any penalties for COVID-19 vaccine wastage. They haven't gotten back to us yet. However, in like other meetings that we attend with CDC, it sounds like their priority is not having missed opportunities. So making sure that if you have a patient there, if you need to puncture a vial in order to immunize that patient and not turn them away, that's their expectation. So just kind of reminders, the COVID-19 vaccines are a government asset. So when you sign the CDC agreement, they are entrusting you with that vaccines, but it does have strings attached, like requiring to ASIIS. VFC vaccines are also a government asset, and VFC vaccines have 5% wastage grace for anything that's unforeseen. Those doses should not be wasted either. For COVID-19 vaccines at this time, we are not aware of any penalties for wasted VFC vaccines. You may be asked to replace those doses depending on the situation or the amount of the wastage. So no changes to VFC wastage at all right now. And remember, just some kind of tips to reduce wastage: only order what you need, account for every dose in ASIIS, and make plans to use your doses. We heard some really good ideas last week from primary care offices that are waiting until they have 10 patients who want a vaccine before scheduling appointments. Other people have talked about using wait lists or calling local businesses at the end of the day. You know that you're going to have wasted vaccine. But remember, like, overall, don't be too restrictive on yourself, because we don't want missed opportunities. We don't want to turn people away when they've already made the decision to get vaccinated. The other thing that popped up last time was some questions about CDC Vaccine Finder. So we're going to launch this poll here to see, are you reporting the CDC Vaccine Finder? And while you're answering that poll, I'm going to actually stop sharing my screen. Angela from ADHS and Jennifer from TAPI have both been doing some research on CDC Vaccine Finder. So do you guys want to tell us what you've learned while they're taking the poll?
Yep, this one's Angela, and then I'll go through some other stuff in just a bit, but she's the one that's the expert on this piece.
Hi, can you confirm that you see my slides?
We see them.
Awesome, thank you.
Very fancy.
They're a little bit basic, but it has the information you need.
Good.
Okay, so for CDC Vaccine Finder, it is one of the requirements as a participant of the COVID-19 vaccine program. You are required to report your inventory daily to CDC Vaccine Finder. You can also use the CDC Vaccine Finder tool to make your site visible to the public. So when the public goes to look for a COVID-19 vaccine, they will see your site. So required to report your inventory, it's optional to make your site visible to the public. So the main thing I want you guys to have is these instructions. So they do have an instruction website, a provider resource page. And so we will put that in the chat here in a bit. I just want to note that when you go to the resource page that has all the instructions, you're going to see a lot of different instructions for the same thing. And it's broken down by jurisdictions and by providers. So jurisdiction is instructions for the state level, for the state. That's for jurisdictions. So you would want to look at the instructions for providers. And then depending if you're going to upload a file every day or if you're going to manually enter your information in, then you would tease out and look for those instructions. So first you'll look for instructions for providers. To get you started with the Vaccine Finder process, whenever you onboard with ADHS, the organization email that is listed where the chief medical officer and the chief executive officer go to sign Section A of the CDC agreement, part of signing Section A of the CDC agreement, it asks for the organization email. So whatever email is listed in the organization email, that's the email that gets the initial registration link to sign up for CDC Vaccine Finder. So a lot of people get confused assuming it will go to the primary coordinator or the backup coordinator, but that email actually goes to the organization email. And you can, if you're searching for it, if you're thinking, I may have seen this email, but I didn't know what it was, so I didn't click on it, feel free to look for Vaccine Finder at off.castlighthealth.com. as the sender if you search your inbox, and you can see if you can find a registration. So this is, you know, a screenshot of what that email would look like that goes to the organization. So once the organization person logs in, they have two choices. You can either set up Vaccine Finder so that the organization will report on behalf of all of the facilities within the organization, or you can set it up so that each facility reports for themselves. So that's one decision you make when you first set up CDC Vaccine Finder registration. And then, and let me just, I'm saying organization versus facilities, so I do want to make sure that we give examples of those terms. So organization, for example, would be like here in Arizona, it would be Banner. So Banner as a whole is an organization, and Banner has a lot of individual facilities located throughout Arizona. So if Banner were completing their Vaccine Finder registration, they would decide, is Banner corporate going to submit the daily inventory for all of the Banner locations, or is each location going to log in and submit their own inventory? And if they choose that each location will go in and submit their own inventory, then that's when the primary coordinator and the backup coordinator on the account will get an email so that they, on the facility level, can register and then submit that daily inventory. There's a link here on these slides to the provider setup guide. And even though this link is on here, if you just have that one main link to the Vaccine Finder resources, you can find all the other links within it. So you just want to look at provider setup. So the requirement is that you enter the inventory daily to CDC Vaccine Finder. Even if you have 0 doses, you're going to log in and enter that you have 0 doses. That way they know you used them all. You're still required to account for doses in ASIIS. I think this has been a little bit of a point of confusion because you have your inventory in ASIIS and then you have your inventory in CDC Vaccine Finder. So both of them should technically match. They should both be accurate and be what's physically in your cold storage units. So both are required. Both ASIIS is required to account for vaccines, and then CDC Vaccine Finder is also required. And the two systems, unfortunately, don't talk to each other. So if you update CDC Vaccine Finder, that doesn't do anything in ASIIS. So each system is separate. I did mention that as part of the Vaccine Finder setup process, you can opt to make your site visible to the public. I will say check the phone number when you make it visible to the public, because it will probably have the primary coordinator's phone number. So always check your phone number to make it public before you make it public. There are instructions on how to make it visible. This is just kind of a screenshot of the options of instructions. So you're going to see here, see how it says jurisdiction for one part, and then see how it says, you know, federal retail pharmacies. You're going to find the one for providers. So for example, this checklist for updating public display fields, the second one down is checklist for providers. So that would be the one that you would look at to help you ensure that your site is visible to the public. So what does that look like? So if you choose to make your site visible to the public, then people can find you and they can come to you to get vaccinated, which is great. That's the goal. We want everybody to be public. So they recently changed it from Vaccine Finder to vaccines.gov. So regardless of which email or which browser name, that's not the right word, but regardless of what you put into the URL, they're going to go to the same place. So you can go to vaccines.gov, and this is what the public would see. So the public, you can see, can choose if they want to look for Moderna, Pfizer, or Johnson & Johnson. Perhaps they need their second dose of Moderna, so they only want to see clinics that have Moderna. So they could make that selection. They can enter in their zip code and search for vaccines. So if your clinic is set as visible in CDC Vaccine Finder, then you will be one of the sites that come up whenever the public makes this search. Another cool thing is Google has partnered with Vaccine Finder. So if someone searches Google for vaccines near them, or even just for vaccines, the locations that pop up, and this is just an example here, But the locations that pop up are locations that are in CDC Vaccine Finder. So they've partnered with them. So you could be visible in a Google search as well. If you have questions about CDC Vaccine Finder, even though I'm trying to give you as much information as I have, I'm actually not part of the CDC Vaccine Finder team that is taken on by CDC. But that instructions webpage, that there's a link here and the link that we'll put in the chat, has a contact link at the bottom of the page. So if you do have questions, you can click that link and send them a message and they can get back to you. And that's all I have for today. So I'll stop sharing my screen.
Thank you. I know we had a ton of questions about how come patients can't see my clinic. So hopefully that if you, we'll make sure that to put those links in the chat, but look at that manual so that you know how to make sure that your sites are public. And Jennifer is going to tell us how to make money. So we've done quite a few billing things. We had tons of questions, the last few sessions about billing. So she will be sure to talk all about her and Patty Gast from our billing office at Chappie, all about billing for uninsured as well. So take it away.
Okay, thank you. And hopefully Bruce and Clark, the two dogs that are with me in the office, won't chime in here as the mailman's going by. But if he does, I'll just pause for a second and try to herd him out of my office. But we'll go through a little bit of billing and coding, hopefully to make money on these vaccines, but or at least break even. But it is complex, it is complicated. There are some policies in place to make it a little bit easier. So the Arizona governor did an executive order that says that all health plans should count this vaccine and flu vaccine as an in-network, no matter where they go. So you can see patients that are not on your roster, that you're not contracted with those health plans, and you can submit the claims. And in most cases, they're paying, but there's a lot of caveats to that. You all know that with grandfathered plans and plans that don't cover vaccines, which Patty will get to in a little bit. Medicare is allowing anyone to sign up to do roster billing through Medicare to be a mass immunizer. So be sure to register if you think that you're going to have patients who come in that are on Medicare, even if you don't typically take Medicare. And the same goes for Medicaid. So if you don't usually take Access, that's okay. Get registered with Access, and you can still bill for the claims for Access patients that may come into your clinics. There's an Uninsured program. There's a new Underinsured program. Patty's going to go through the instructions on that because it's been very, very complicated. And I know that everybody's struggling with it just a little bit. The important piece to remember here is there is no patient out-of-pocket cost. You can't balance bill the patient. You can't ask them to do a cash pay for the administration of the vaccine. You cannot charge the patient anything, which is why they've done all of these policies and additional programs to make sure that you're whole, even though you can't bill back the patient. And I know this has been really tough for people because you get a denial or you get information back that says that they owe a copay and it doesn't apply to this vaccine. You can't charge that patient. So we do have a full set of these slides that are located at a link on our website that actually has a little bit more information about it if you need them. We also have put together kind of a patient handout or printout that you can hang in your office as a larger size or just print out and hand to each patient. And this explains what you need to get from them in order to bill for the vaccine, whether they have private insurance or Medicare, because under Medicare this time, you don't use the Advantage plan number that you typically would. You use their Medicare ID number or their Social Security number, and that's different. And this has been really tough for Medicare patients because they're very used to saying, nope, you need to bill my Advantage plan. So this kind of explains to them why you're asking for that Medicare number. We also ask for Social Security numbers and driver's license numbers of patients who are uninsured. And so this could be a barrier, but you need to explain ahead of time that no ID or insurance is required to get this vaccine. They'll still get the vaccine if they don't provide that, but this hopefully explains a little bit as to why you're asking for that information. And then Patty will go through what you do if someone doesn't have any of the IDs that you've asked for how you can account for that and still be paid for it through some of the programs. So just some things to note. There are some potential changes in your workflow for how you bill for this vaccine and how you account for it that might be different from how you typically do vaccines in your office. So you be sure to scan the NDC from the box and not the vial. So typically when you're putting together a billing claim, you would put the NDC number for the actual vial of what was given to that patient. But in this case, because you're doing reporting to ASIIS and you're tracking the inventory from the CDC, that number comes off the box. So always use the box number. And most of the health plans are saying it's perfectly fine to use the box number, not the vial number in this case. I know there was one plan that was denying those for a little bit, but I think they've undone that, and ASIIS did a policy recommendation to take the box on those claims. So if you're still experiencing that problem, contact ASIIS or the ASIIS Health Plan to remind them that the box is what's required. So you document in the record as a federally supplied for that inventory, for inventory and reconciliation and billing. So it's federally supplied. Sometimes you use that SL modifier on it. Some plans are taking the SL modifier, some prefer that you don't use it. So it's kind of at first just getting a feel for what each plan expects and how they have their system set up. So we'll talk about billing the HRSA programs in just a little bit. But the way that you bill this is $0 for the vaccine, because you receive the vaccine for free. When you bill the vaccine, you put in $1 of zero, and then you bill for the admin fee. So prior to 3/15, it was $16.94 for the first dose and $28.39 for the second dose. But after the 15th this year, they bumped that up to $40 for either dose. So hopefully that'll make you all a little bit more whole on this by getting $40 for the vaccines that you're giving now. So you bill under the physician or global standing order. This is especially if you're doing off-site clinics. So typically you're used to kind of billing under whichever provider ordered the vaccine. But if you're hosting a big clinic, you usually have one provider that will write the standing orders for that clinic, and you bill under that provider's information. And then if you're going to do it off-site, like at a church or a parking lot of a nearby facility, you use a place of service code 60. And that way it lets them know this is not happening in your typical office setting. You've gone elsewhere with the vaccine, and there's a specific code for doing off-site clinics. One thing that we heard this week that some people were getting denials because of the diagnosis code. So on vaccines, you use a Z23, which indicates that this is an immunization visit, so that you don't have a specific diagnosis for that particular patient. You just use a generic immunization diagnosis code. That place of service code 60 goes right here if you're off-site. That NDC from the box goes here. Some of the plans are requiring that you bill the vaccine code that's associated with that for $0 or 1 penny. Some of their systems will kick it out if it's $0 and assume that it's a false claim or that there's something wrong with it. So if you're finding that, put in 1 penny. Most often the plans won't pay you for that penny. Some of them will, some won't. But the big piece is getting that vaccine administration code on the next line, and that's where you put your $16.94, your $28.39, or $40, depending on the date of service and the dose that was given. The rendering provider is the provider that wrote the standing orders that's part of your base of operation. So it could be your clinic's rendering provider if you're part of one of the large organizations that does a global standing order. You would still put that information in there, or wherever the physician who wrote the standing orders, where their clinic is. So that's just kind of some of the overview of what that'll look like. The important pieces to remember are that location code of 60 if you're off-site, standing orders from whoever is kind of overseeing that clinic, and then bill $0 for the vaccine and $40 for administration. And that $40 is going to help a lot. These I just put in here so that when we post them, you have them. These are all the CPT codes for all the different vaccines, the different doses, and then I've even included some of the vaccines that are pending approval right now so that you're ready to load those into your system and have them ready to go when they're out. These are some important links to just check frequently. CMS and ASIIS changes their policies almost on a daily basis. So just kind of keep apprised of what's happening and what's changing. Because even as we finished these slides, Patty and I were kind of working together yesterday, coordinating them. I was going to end on the uninsured program and kick it over to her. And then we got a tweet yesterday afternoon that HRSA has now established, HRSA and Biden have established the Coverage Assistance Fund for patients who are underinsured. So this is that patient where you get the notice back from the insurance company that you need to collect a copay or that they're not going to cover the vaccine. So when you get that denial, now we have a new underinsured fund that you can submit that to. We've had the uninsured fund. This is a patient who has no insurance whatsoever that you can not charge the patient because you can't charge them anything and submit those directly to the uninsured program. So with that, I'm going to turn it over to Patty, who knows a lot more about the uninsured program than I do. Were there any questions about that part?
And I wonder
Anybody
if you
have any
a
problems?
question, if you want to, unmute yourself. We see some in the chat, but I don't know. I think Patty will go over some of those. So go ahead and unmute yourself if you have a question so far. All right. Well, Patty, take it away. I think this is where most of the questions are anyway. And we don't hear you, Patty, so you'll need to unmute. We still don't hear you. We see you. I wonder if maybe she, Nicolene will probably chat with you on in the chat. Maybe you can call in. I don't know if the Patty will cover this or not, Jennifer, but one that came in while we try to get Patty on the phone line. Do you have to create a new ID for self-pay for their second vaccine?
A new ID for self-pay. There shouldn't be self-pay, but I could be confused about the terms. So that we shouldn't have any patients that are paying in cash. For Vaccine Finder, if that was related to that, you do have to report all of those doses to Vaccine Finder and ASIIS, even if you typically wouldn't. Because all of this is federally supplied, you still have to report all of the doses to both systems.
Okay. And then there was a question in there that's ASIIS related about that PHC report that Maggie's talked about in the past. Maggie's not in today, so we're going to hold that question until next week. And if you remember it, ask it. We'll make a note to try and remember to ask it too when Maggie gets on. And I think that Patty, you are connected now, but it looks like you're on mute. So try to unmute yourself.
Got it. So
Yay,
hopefully, I apologize. I was on the phone the whole time, and for some reason, I had to put in an extra code to sync my audio. So I really apologize for that. So I'd like to go ahead and go through our experiences here at TAPI with the uninsured billing program. And let me try to move my little thing here. There we go. And these slides are pretty wordy at this moment, but they're there as a guide for you all. So hopefully it's kind of a one-stop shop with a great flow that you can follow in your offices in trying to navigate this uninsured program. And at the end, billing for the underinsured patients will cover a little bit as well. And my slides aren't moving now, everybody. Oh, there we go. Thank you. All right. So many of you have already been to the HRSA website. They have some great materials there for you to use. Here's the link, and we know that they are providing reimbursement for individuals who, for providers, for individuals who are uninsured, and that includes for any COVID testing services, treatment services, or vaccines. And today we're going to focus mostly on vaccines. So we're going to talk about enrolling in the program today, collecting additional patient insurance information, submitting the rosters to the uninsured program to get a temporary ID in order to submit a claim for the patient, attesting to certain requirements that the program has, receiving a temporary ID for the uninsured patients, and submitting electronic claims to the uninsured program and getting those payments back. So basically the whole shebang. And the purpose of this program is to make sure that providers are whole so that there are no barriers to patients getting their COVID shots. So this program will allow you to bill for any patients who don't present with insurance information to bill for. So this uninsured program will reimburse providers the Medicare rates that are published on the Medicare website. And the program is being administered through the UHC, United Healthcare Optum program. And the requirements include having a UHC contract and an electronic payment set up with the bank. And it also requires that you submit electronic claim submissions. They're not allowing you to submit paper claims. So if you already have an Optum contract and you have an Optum payment account along with electronic payment setup, then it's quick and easy to enroll in the uninsured program. A few clicks and you're almost ready to go. However, if you don't have a contract or don't have an electronic payment setup, you do have to go through a lengthier process. So when you are registering, you have to attest to several requirements, and these are very important. First, that you've checked for your healthcare coverage eligibility for your patients, and that they are not insured, and that you will accept reimbursement as payment in full from this uninsured program, that you will agree not to balance bill the patient, and that you will agree to other programs, terms, and conditions, and that you would be subject to possible post-reimbursement audit review. So how does it work? You first have to submit an individual patient roster or a batch, so a list of patients on the uninsured program portal that you've signed up for. You will receive a temporary ID for that patient within 24 hours from the uninsured program, and then you will place that temporary ID onto the electronic claim that you will submit to the uninsured program for reimbursement. It's important to note that when you are submitting the roster, only one staff member is the person who is designated as the uninsured program administrator, and that person has only one set of credentials. So that person is supposed to be submitting the rosters and attesting to the compliance with the requirements, but we were advised that you can also share that information and allow other people to do it in your practice, because sometimes that one person is just not always there. But ultimately, that administrator is the one single person with the one single sign-on that should be submitting the rosters. And then when you submit the rosters, they're asking for a whole lot of new and not typically collected information for billing purposes. So let's go through what that involves. First off, they're requiring, your billing TIN number, the patient name, first and last name, the date of birth. Then they're asking for an ID type, and they're asking for either the Social Security number, a state ID number, a driver's license number, or there's also no ID number. And then here you place the ID number in here. They ask for gender, patient account number, the address, all the way down to the zip code. And then they ask if you are a professional, like a doctor's office, or if you're some type of institutional submitter. The date of service is required, and also the admission date and date of discharge. These may not be applicable on the typical doctor's office submission. I'd like to cover some of those tricky elements about that additional information that's needed. If the patient doesn't have an address, then be sure to use your clinic's or your doctor's office address wherever it was rendered. So this would be for like somebody who lives in a shelter or is homeless, or they're for some reason hesitant to provide their home address. They're also asking for a driver's license or social security number. That's to verify that the patient truly isn't covered. When you submit this information, they're going to look through their coverage detection system at the Uninsured program, and they're going to try to find that coverage for the patient. And if they do find it, they will sometimes give that information back to you so that you can bill their insurance directly. So what they're trying to do is verify that each person is an individual and that they got the right person. So in an ideal world, we would normally want to copy the driver's license or social security card when we encounter that patient and keep it with our encounter paperwork, or we at least want to ensure that our staff proof the number carefully when entering the data. But that often is not always the case, and we do the best we can to collect that data. We also know that patients are often hesitant to provide this kind of information. Once you've encouraged them but don't want to discourage them from getting a shot and they still don't provide you with that information, you can go ahead and select no ID. That was one of the options in the fields that I shared on the previous screen. For children, you would also indicate no ID. Again, they're asking also for the state of residence, and that's so that they can link it to the driver's license number or the state ID number. And then, of course, the patient's date of birth is important to provide. And the key here is that if the information is insufficient or incomplete, go ahead and submit the roster line anyway. It may take more time to get approval, but usually we found that we do get approval, we get a temporary ID, and we're able to bill the claim, even without some of this additional identifying information. When you submit the roster, you have to attest to certain elements that are here on the screen, and that you're submitting on your own behalf, and that you're associated with the provider who's associated with the TIN, that you're not trying to defraud the government, and that you have your official name and email in place in case they need to contact you, and you understand that only one person may submit information for a provider group under the TIN. And then once you submit that roster, you're usually going to get a member ID, temporary ID number, within 24 hours back through that roster process. And you will use that on the claim for the subscriber ID/policy number. If all required data elements are not provided, then the program may take longer to process and give you a temporary ID. And we waited as long as 1 month in order to get that temporary ID from the Uninsured program. When you submit the claims, again, you submit that temporary ID as the member ID in the subscriber field for adjudication. And the timely filing period for submitting claims is 365 days from the date of service, and this is specifically for the Uninsured program claims. When you submit the claims, you submit them through your normal electronic claims procedure. Again, remember, there's no manual claims submission. It must be electronic. And you will send it to this payer. It's the COVID HRSA Uninsured Testing and Treatment Fund as a part of the United Health Group, which Optum is under. And you have this additional information here about their address. And most importantly, the payer ID is down here at the bottom of this slide. So the uninsured program will only accept the immunization admin CPT code and not the vaccine CPT code on the electronic claim. So do not submit the vaccine CPT code when you are submitting your claims, only the admin code. If you do include the vaccine CPT code on the claim, the uninsured program will reject the claim. And as we stated earlier, it won't accept paper claims. And they will only make payments electronically to your bank account. You will not be able to receive checks, etc. And really critically, all uninsured program remittance advices must be pulled down manually from the Optum Financial website. So you will not be receiving any EOBs in the mail, no checks in the mail. You will not be getting any electronic remittance or ERA back from the payer. You have to go to the Optum Financial website and pull down your remittances, and then you can upload them into your electronic system. And you can either upload it manually by typing the information in, or you can pull down electronic remittances that can automatically upload into your system. This financial piece of the website allows only 2 users. And so we've had trouble with pulling down the EOBs from that website. And so we've tried to make sure that we have a contract with UHC Optum that allows multiple users to be able to do that. That involves a contract that has some additional charges to it, but it's pretty nominal in nature. And I'd like to explain that that's been our experience. You might be set up differently with Optum and United Healthcare, but this has been kind of problematic for us in that we have such limited ability to pull down the EOBs manually from the financial website. All right, so the last big piece about the uninsured program that I want to mention is that HRSA disallows double dipping, and the funding that they're using for this uninsured program is from CARES Act funding and other different federal sources of money. So if you're getting grants or some types of reimbursement from the federal government to offset some of your costs, this money that you're getting from the uninsured program could kick in some reporting requirements if you hit a certain threshold. So, and that threshold appears to be $150,000 per the second paragraph on this. Normally, if you're not getting any special sources of funding, like from the Provider Relief Act or something like that, then you probably don't have anything to worry about unless you hit $150,000 of reimbursement from this uninsured program. So that's the key where they want you to report. But again, only if you hit this very large threshold. And then also they want to make sure that you're not double dipping and paying yourself for claims from, let's say, the Provider Relief Fund, and also now pulling down from the uninsured program. If you'd like more information on this, we can certainly work with you one-on-one if it's confusing or you need more help with it. And then I'd like to mention the Coverage Assistance Fund, and that's a new program that HRSA has put together, and this is for patients who have insurance, but the providers are not getting fully reimbursed because of the COVID vaccine not being covered, so the providers are not getting reimbursement from the insurance company, or because a patient out of pocket, like a deductible, copay, or co-insurance was assigned. Most insurance plans are required to reimburse fully the COVID immunizations. However, there are some exceptions, such as plans that are grandfathered from the ACA, some short-term medical plans, and other plans that don't fall under the ACA. And some of those might be some self-funded plans. So there is a whole new separate program that uses totally different logistics in order to be able to get reimbursed for the patient out-of-pocket or denials that you're seeing for patients who do have coverage insurance. But the goal of this program, again, is to make providers whole and to ensure there are no barriers to patients receiving the COVID vaccine. So the challenging piece with this is you have to bill the insurance company first, get the denial or the short payment, and then you have to submit that information over to the Coverage Assistance Fund. The Coverage Assistance Fund is more of a direct program. They require that you register with a different portal. They allow you to submit claims only electronically, and you can do that through a clearinghouse, or you can manually upload claims through the provider portal. So there is a really great website that they have with tons of information and some upcoming trainings on this. We haven't had much experience with it, so I don't have very much more to share about that beyond what I've just shared with you. But as usual, nothing is, you know, simple or easy. It seems sometimes with the billing process, it certainly is complex, but I think solutions are being presented to be able to help providers not lose money on getting people vaccinated. So I'm available, and also David Babani with our program. He's also available to answer your questions anytime. You can ask it a part of this program, or if you have questions as you go along on billing, we're going to try to always be available to help you all in navigating all these different systems. So that's all that I have right now. Does anybody have any questions, or do we even have time for questions?
We do have time, and if anybody wants to come off mute, they're welcome to, but I did have one in here that I said that I'd follow up with you on. So they have noticed that in some plans, they're paying all over the place. They're not paying the full 40. The example that was used is Blue Cross Blue Shield sometimes has paid 16, 18, 22. But they have not ever received the total 40. So they kind of said, should they resubmit those claims, or should they just take what is offered? Do you guys have any experience with it?
This is David. So what I was going to say is that what Blue Cross is basically doing is, if the provider has a contract with Blue Cross, they're paying according to that contract. So for example, if the provider has a contract that calls for 80% of the Blue Cross schedule, they're basically discounting the $40 by 20%. Now that doesn't explain, you know, why the amounts are varying from $1 amount to another, but I can tell you that that's Blue Cross's position, is that they will discount it down to the contractual agreement with the provider's office.
And then let me jump in with that. We've seen varying reimbursement rates too, and we're in the process of working with plans right now to try to figure out what in the heck is going on and why we are seeing that. We're not seeing any out-of-pocket assignments on those.
Sí, están también ya vacunando a la población.
So I think we might have more information to share about that, but it might be something to follow up with your provider representative at the plans if you are seeing varying rates. Some of it is a little concerning. I think we're still seeing low reimbursement rates from one major plan in the state that like the rate was not completely updated until very recently. And so we're still getting those low reimbursement rates past that March 15th date by which CMS upped the reimbursement rates. Another thing to note is we did speak with Blue Cross Blue Shield, and one of the first answers that we did get on some varying rates is that they weren't able to update their system until relatively recently with the new higher reimbursement rates, and that they have no obligation to go back and pay the higher rates previous to that, because they said that they are not under any CMS requirements, et cetera. So we're taking that up with them as well, and hoping that they'll be a better partner to everybody in the state trying to get everybody vaccinated.
Yeah, and this is David. This is David again. Cigna is another payer that was tardy in updating the fees, the reimbursement fees. So that could be a reason why providers are seeing underpayments. I believe that they have already updated their system now to pay at the higher rate. I've been going back and forth with a contract rep that we have here at TAPI, trying to see they will go back and reprocess the previous underpaid claims. I don't have a response back as of this moment.
So are you guys, because there's also a comment here that they're seeing that with Banner University and Health Choice. So are you guys finding the same thing with the Access health plans? Because Access was pretty clear that their policy is $40 for reimbursement, and that's a CMS and a Medicaid policy piece. So how are you all noticing, what are you noticing with the Access plan?
So we're noticing that, yes, we have seen some underpayments in that regard, and we have circled back to the plans, not only on our behalf, but on the behalf of all providers, to say that these claims need to be reprocessed. We haven't received necessarily any indication about any major reprocessing projects or anything like that, so I can't tell you that they're in the works. But we've taken some of these issues forward with some of the plans that we've been experiencing the same thing with. And then TAPI is always in touch with the main Access office, and we're definitely sharing that information with them as well.
Okay, and then and we'll try to we'll ask Access if they can send another reminder to the health plans, to get the systems updated. So the other question is prior auth. Some are getting denials needing prior auth, and I think you guys have noticed that that's coming up as well. Should not be the case for vaccines, but there's a lot of shoulds in vaccines.
This is David. I think that one possibility with those particular denials, it could be that these patients have an HMO. And if they have an HMO, even for vaccines, a lot of these payers still require that prior authorization from their PCP. So, without knowing the specifics of those claims and, what type of coverage or what type of products these patients are covered with, that's my immediate guess, is that these patients are covered by an HMO product of some sort.
So I'm not sure, how is anybody else managing that, especially in open walk-in clinics? You don't have a process in place in a walk-in clinic to get prior auth.
Right. That was my question. Why? What do we do in that case?
Well, I think we're trying to uncover exactly how to handle that as well and educate the plans about those pieces. But yeah, it's very concerning that there are just so many different ways that we're not getting reimbursed that we expect reimbursement for. So I don't know that we have any good answers at this point. If you can get prior auth, great. If you can't, need to educate the plans that this is something that should not require a prior authorization.
What are there specific plans that are doing the prior auth but not others?
HMO plans tend to do a prior auth sometimes, although we don't normally see that a lot with regular immunizations either. So it could be that their systems just aren't really well set up yet to handle all of this. And unfortunately, this is going to be a lot of AR work that I think providers are going to have to track through time and see if, it can't get resolved.
Well, and this is where that new Underinsured program is being set up to help. So if you've been denied because of prior auth, or it's not covered, or they say they need a copay, then you can submit those to that Underinsured plan. It just started yesterday, so we don't have a lot of details about it and what that's really going to look like. But I think that's why they're putting these programs in place. They understand that you guys are trying everything that you can to get these clinics set up and to bill them, but you're not always being paid and you're not always whole. So I'll be curious to see what they come back with in the end of like those times where you found that you got paid $15 on a $40 claim, if that will go you know, if that'll be considered an underinsured. And like I said, it just started yesterday, so I don't know. Oh, Roxanne's got some information on it. I'll see if we can pull that out. And then, Patty, on some of those where you guys are not sure because people are not filling out the information correctly, you guys have been sending some of those to that uninsured plan, and then they send you back health coverage information?
Yes, exactly. So they must have some type of coverage detection system so that when we submit to the uninsured program, rather than sending a member ID back, they'll actually send the patient's insurance information, and we're able to bill from that. It's not real consistent, and so we're not really sure how well their coverage detection system works, but on top of that, they're not able to find the patient's Medicare ID number, just like we're not. So if somebody ends up having an Advantage plan through, you know, a major commercial carrier or whatever, like United or AARP or whatever, you don't bill that to the Advantage plan. You have to submit it to Medicare, and so many of the patients don't have their Medicare ID numbers. So we were hoping that this uninsured program would help us find those Medicare ID numbers, but they're not able to find them either. So the issue is, in order to look up the patient's Medicare ID number in the Medicare ID portal, you need the patient's Social Security number, or you need their member ID number. So if you don't have either of those and you only have their Advantage plan information, you're not able to track down their Medicare ID number. Now, some of the commercial Advantage plans do actually have the ability, allow you to look up the Medicare ID number on their website. So, and ASIIS sometimes has that information too. So if a patient has ASIIS and an Advantage plan, sometimes they have the Medicare ID number there. United, I believe, and Blue Cross, Blue Shield, and Humana also often have the Medicare ID number there. So you can do those additional lookups in addition to trying to track down the Medicare ID number, because maybe there's just a typo in it or something, and you can end up going to the Medicare portal for that information. Or if you get that really important Social Security number.
Okay, and then thank you. And then the other, what Roxanne just found, and I'm gonna put it in the chat now, on that new underinsured program, it says that vaccine administration provided to individuals whose healthcare coverage does not include the vaccination administration as a covered benefit, or only provides partial reimbursement. So if you've gotten paid, you know, 16 or 13 on what was a $40 claim, legitimately, it looks like you could submit it to the underinsured program to get the rest of that $40 back. And it's just started yesterday, so we'll see how it goes.
Well, I think that a lot of these things, as you resubmit claims or don't resubmit claims or test out that underinsured program, you know, bring those, what you're learning, to the chat box on the COVID tips, because it is unfortunately just, it's going to be a bit of trial and error and working with AR and chasing things down. So I think that it's always valuable to get the billers together so we can get some of these questions. So hopefully, I'm sure this won't be the last time we talk about money, but Patty and David too are, you know, they're doing this statewide with every plan that walks through the state. So please reach out to them and use them as a resource. That's why we're here at TAPI. So is to be your resource and to support our members. So please reach out to us. I want to launch a poll quick about next week. We don't have a topic in the hopper. So would love to know what you'd like to spend most of our time on next week. So do you want to talk about pods, ASIIS, Do you want to talk about immunizing pediatric patients, kind of hoping, assuming, crossing our fingers that Pfizer will be down to 12 by the time we meet again? Do you need more ASIIS? Go ahead and just take that for us. And it is 1 o'clock. We'll kind of keep that open, and we can probably keep the line open for a little bit too if more billing questions come in on that chat line. Does that sound, would you be able to stay on, Patty and David and Jen, for just another 5 or 10 minutes?
Yep, sure. Free.
Okay, great. I have another call, so I'll probably log off, but I'll wait to see what the survey says.
Survey says.
Happy Nurses Week. Then go ahead, keep answering your questions, Jen. You're getting more in chat.
Thank you. So what about timely filing? Well, we're in debate about that too. A whole lot of plans are telling us that we've hit timely filing. And yet, like yesterday, we were even looking, and on the federal sites, it says that timely filing has been suspended on all medical claims until 60 days after the end of the pandemic. So that should mean we don't have any timely filing, and yet we're bumping up against it too. I don't know if Patty and David, if you found any more information about that.
We don't have anything additional to share on that, but we're trying to really get to the bottom of it. And it's disappointing because some plans have information on their websites about how timely filing has been suspended and others don't. And their staff and the way they handle claims does not seem to be in line with what we believe is the federal requirement. So we shall see.
And again, just let us know what plans you're running into. I mean, it's not, we can't fix it all, but we can try, or at least, you know, start discussions with different groups about overcoming some of the obstacles that you're finding. So just let us know what plans and what concerns are coming up. Any other questions or things that you're running into? Can you clarify the $150,000 reimbursement amount? Oh,
right. So that has to do with the uninsured program. And what it's saying is that if you receive more than $150,000 through the Provider Relief Fund, the CARES Act funding, and a variety of other funds, and that would include the uninsured program, you might have to then do special reporting requirements. So the average provider, I don't think, is going to get $150,000 from the uninsured program. Maybe they will. And then reporting requirements do kick in. Anything over $150,000 from any of those federal sources, including the uninsured program, and I haven't seen it regarding the Coverage Assistance Fund, but I bet you it's the same kind of funding, so that will be lumped into the pot as well. But I think a lot of folks don't need to worry about this. It is there, though, for the providers who are participating in the Special Provider Relief Fund and getting other kinds of CARES Act or other grant funding. So I hope that's clear, and I don't think it's something that you totally have to worry about, but someone at your clinic or organization would be aware of what grant funding you're getting or any other special types of federal funding not related to billing that the uninsured program would contribute to and maybe kick you over that $150,000 reporting limit.
Have you seen anything or any guide on what that other reporting requirement will look like? You know, is there stuff that they need to start gathering now to be ready for it, for those that are going to go over?
So that's a good question. So basically, when you receive the CARES Act funding or the provider relief funding, et cetera, it's part of your grant requirements or however you're receiving that extra additional money. That is specified that you have to then, and if you're getting over $150,000, it's specified in those grants. as to exactly what you need to report, but it's basically an accounting of the different funding sources and how much money you're receiving. It's just for an audit trail or whatever. I have not seen details about that in the uninsured program billing, so I've not plowed through that ourselves, but just like that other program funding requires reporting, it would be the same type of reporting in the same type of format, and this would be like an additional line that you would put in for your reporting of the other grant funding that you have to do, if that makes sense. So it would just add to what you're already reporting. If it's new reporting because you're receiving over $150,000, stay tuned. We're going to be looking into that ourselves just to help big providers out.
Okay. Does anybody else have any questions? Or feel free to come off mute and just throw them out there too. Okay, well, it looks like we're kind of starting to wind down. So if that's the case and we don't have any last minute questions, then we'll go ahead and close down for today and then plan on seeing you next week. I know we've got, some suggestions on reporting to ASIIS is still a hot topic. And it looked like the second one was those pediatric vaccines, planning for it going down to age 12. And then being ready to get Pfizer vaccine in your office because it's got some slightly different storage and handling requirements. So we'll kind of take a look at all of the suggestions and see what we can pull together. And in the meantime, if you have anything that you need help with, just let us know. Send us emails, and then we'll kind of continue to put things on the list so that we make sure that we get to them when you need them. So thank you, Patty and Angela, for going over Vaccine Finder. We've had a ton of questions on that and billing that the rest of us can't answer. So we certainly appreciate you being here, and David, you as well. Thank you, guys.
Thank you all. Bye-bye.